Several years ago, I was invited for a conference at University of Berkeley, San Francisco, to give a talk on artificial intelligence in medicine. And I got down in the airport and I showed my invitation to the customs officer. Then he asked me, "Do you have anything to declare?" Then I told him, "I have nothing to declare except my ignorance about artificial intelligence in medicine." Then he laughed and shared this with his colleagues. Then I asked him, "Is it taxable, ignorance?" Then he said, "Ignorance is not taxable in America, but knowledge and wisdom is taxable." Okay. Having said that, at that time, in 2017, artificial intelligence in medicine, we never thought it had any relevance. It has something to do with only engineering, technology, software, Silicon Valley, and all these areas. It has nothing to do with medicine, and we didn't know much about it also. But I still gave a talk and learned more from my ignorance than my knowledge at that time. But today, artificial intelligence is everywhere. So, all aspects of medicine, in diagnosis, treatment, decision making, follow up, prognosis. Prognosis is the most difficult area in medicine, but artificial intelligence helps even in prognosis. How do you move forward with all this? I'll take you through a few examples of so-called innovations in medicine, what we went through in the last few decades. So in 1985, any of you knew the heart has four valves. The most important valve was on the left side of the heart called mitral valve. Stenosis of that valve is called mitral stenosis. The commonest method by which the stenosis of the heart valve, mitral stenosis, was treated was by surgery. It was few decades old, nearly 6 decades or more old, say surgical skills, both open commissurotomy as well as closed commissurotomy were standard procedures. Then at that time, when Professor Zoltan Turi from Harper Hospital, Detroit, came to us and proposed the idea whether we can try to open this wall by a balloon mounted on a catheter without opening the chest through an artery or a vein. Then that idea was considered very unusual. We had discussions amongst ourselves. We used to work as a team in Nizam Institute of Medical Sciences at 95 or so. And then we shared this with our surgeons. But it was not very welcome idea at that time. How can you do a blind procedure on a narrowed heart wall and still think that you can deliver as good as surgery? So it was taken with a lot of pinch of salt, and then we had to convince them, go out of the way, and then told them, we also feel that we don't know how it works, but let us try. Then we did two prospective randomized trials of around 120 patients and immediate results and later follow up for 3 years or more. And then we found the results were available on not only immediate results but follow up results. The study was published in New England Journal of Medicine in 1994. Until that time, this procedure never seriously taken. The results were that surgery and balloon dilatation, the results were almost same. And without opening the chest, you could open the heart wall. So the whole world took over that from that studies, and that was the first time a randomized clinical study was done in valvular heart disease in the world. Not only we showed the way that time, thanks to my colleagues and everybody involved in it, that laid the foundation for later structural interventions dealing with them by catheter. So present day outside coronary arteries, a lot of procedures on the heart are done, including aortic valve replacements, dilatations, whatnot, based upon this study. So that was our first innovation. We didn't invent it, but we innovated it. So evidence is most important component in practice of medicine. Next, come to 1990s. We used to do angioplasties for narrowed coronary arteries that time, but the arteries used to close off either immediately after dilatation, requiring emergency surgery, or restenosis rates and requiring another procedure or surgery used to be quite common. Then came the stents, metallic stents, in 1990s, which takes care of the narrowed, say, coronary artery. Immediate closure is highly unlikely, and later restenosis rates were also far less. But the stents were made available, not in this country, all over the world, but the costs were extremely high. In 1990s, the cost of a single coronary stent used to be around 75,000 rupees, which was more than the cost of either surgery or angioplasty wholly done. So then, incidentally, that time, while we are going through this, one Defense Research Organization of Hyderabad, one of the employees there, a scientist there, fell ill. He had a cardiac problem. And then he was admitted with us. Then, to see him, Professor Kalam used to come daily. He was the chief of DRDO that time. And incidentally, we also shared with him what we routinely do, and we showed him the stent that a lot of people can't afford it, and then, but this makes a difference. Then he said, Dr. Somaraju, when we can make missiles which are heat resistant and then last so long, why can't we make a metallic stent which is so small like a watch spring? So then he requested his colleagues to work on it and then came out with a metallic stent, and which we tried in first in animals, then humans, and then the stent was finally available. So then this was called Kalamraju stent. So compared to the imported stent, this costed only 15,000 rupees. So nobody needed to be denied coronary angioplasty or stenting because of this. So in other words, what is important here is innovation in medicine is not just availability of something, but make it happen to largest number of people and helping them. That is medical compassion, innovation carried to a compassionate scale. So the next area I would share with you is that we used to have in the cities, tertiary care hospitals we used to have, and we used to have all the facilities. But back in the smaller towns and rural areas, the patients had to come all the way to cities and towns, and then they didn't have access to medical care. So neither medical opinion nor facility was available. 2001, we started the idea of telemedicine, and along with the again DRDO, Professor Kalam was there, and one of the people standing behind him was Professor Tiwari. He was the one who was first admitted with us at Nizam's Institute, and Dr. Kalam came to us. He is sitting in the audience today here. So he is the connection. We say in medicine, the patient is the connection for everything. So he was the connection for all these things actually, one after another. Then you can see that that time we started working as a public-private partnership with the government and delivered telemedicine and delivered opinions, both ultrasound, CT scans, etc., and give opinions, trained the local doctors, and then patient didn't have to travel all the way to cities. That's how it worked out. Today's medicine is so advanced, so much of technology is involved in it. So much can be done, molecular biology, genetics, etc. And then you don't understand the present day technology and present day medicine unless you have knowledge beyond biological science and clinical science. Most of us doctors were trained in biological sciences and clinical sciences. Then, but we have no idea of mathematics, physics, chemistry is biology now, and then management skills, social skills, etc., were completely lacking. Now, this third component of education is called health system science, that we were lacking that time. Then, artificial, as if all this is not enough, artificial intelligence suddenly evolved into something very important even in medicine. A lot of hospitals today try to use electronic medical records. If you go to any of the hospitals, they will tell you it's working very well. It's not true. It's not working well. You know the reason? We doctors don't understand technology, don't understand this digital technology and computers. So it's not working out. So, in other words, It is extremely important now that we also understand artificial intelligence. There are two types of opinion expressed about artificial intelligence today. One is it will drive out doctors. Doctors won't be needed in future. Another is that it is a myth. It's not true. Both are wrong actually. Artificial intelligence is extension of physician, augmentation of our intelligence. So in other words, if you need a second opinion, we always used to talk to our other colleagues, other knowledgeable colleagues. Artificial intelligence is the best second opinion colleague to you now. So when do you take second opinion in medicine? Number one, when you don't know. Number two, even when you think you don't know, you know, because medicine is an uncertain science. You don't know when you don't know. Third is, you suggest a procedure or a test which is going to change the life of the patient significantly, or the patient's life is in danger or disability, in which case you will go for a second opinion. So artificial intelligence is that great second opinion person or your colleague today. So we have to use it, and there is no other way. With all these advances in medicine, medicine is moving away from patient-centeredness and bedside medicine. That should not be ignored. Any of you or your family members or friends went to a doctor, you would have seen the doctor doesn't even talk to you adequately. The doctor even doesn't even touch you. Only tests. Is it true or not true? It's true. So bedside teaching is fundamental to continue our patient-centeredness and humanism in medicine. Okay? Then you can't change all this unless you change the education of the physicians or doctors now. In the words of Dr. Deming, quality engineer in US. So in other words, management or the way you work cannot be changed unless you change your education. Then, so medical education has to be redefined. So present day it's not enough. Present day medical education is no longer enough. We have to involve for all this health system sciences to be educated. We need a hospital, a university, a technology institute, public health foundation, and software company. So then, how do we make all this possible? In the words of a famous pathologist, Rodolphe Virchow, medicine is a social science, and politics is nothing more than medicine on a grand scale. So, in other words, unless you have right type of platforms and right type of governance, none of this can be achieved. Transformation of medicine in the possible future we are talking about. So you can see here, we need politicians who can make this possible in future. So in other words, I am not saying that you take up to politics as a doctor, but don't ignore it. How do you make politicians listen to you? By patients' trust. If politicians know people listen to you and they have trust in you, you can modify the way people vote. Then politicians will listen to you. Thank you.